Good afternoon, Dr. Haitham.
Is that better?
Can you hear me?
Yeah, I'm hearing you.
Okay. Thank you, Dr. Haitham, for joining.
Thanks very much.
Before I start, where are you from, Dr. Haitham, if I may know?
Yeah, I'm from Palestine.
You're from Pakistan,
Palestine.
Palestine. Okay,
Yep.
okay. Very nice to meet you, Dr. Haitham.
Thank you.
And what are you doing at this moment
Uh,
of time? So,
yeah.
what kind of
Uh,
training in critical care you have received so far? So, I just trying to understand. Uh,
yeah.
this important.
I did a fellowship in the intensive care in Hadassah Hospital in Jerusalem, and now I'm running
Okay.
the intensive care unit since about 3 years.
Okay. So you're there in the intensive care unit for approximately 3 years.
Yep. I'm running
And
that after fellowship, so I'm working intensive care since 5 years, almost like something like this.
oh, very good, very good. And you are preparing for your EDIC 2 exam at this moment.
Yeah, sure. Yeah.
Yeah. When is your exam, Dr. Haitham?
My exam is in the next exam, like next autumn. Yeah, on the 27th of November.
Okay. I hope this mock test will help you in your
Okay.
overall preparation. So with this thing, can we start?
Yeah, sure.
Yeah. Before we start, I'll just tell you. So this will be kind of EDIC on the basis of the EDIC Part 2 examination. EDIC Part 2 examination is has two important scenarios. One is CCS, that is a clinical case scenario, and another is case-based scenario. I hope you are aware about the fact.
Okay.
And before I start, again, one important thing is that in clinical case scenario, you'll be given one case vignette, and you'll be asked several practical based question on the clinical case vignette, and you are expected to reply in a very to the point and very particular way, not to override your answers and all.
I see.
And your answers has to be very time bound. Like in our clinical case scenario, we'll be having almost 20, approximately 25 questions, and we have been given half an hour for that thing. So each answer has to come within 1 minute. So,
Okay.
and the questions will be framed also accordingly. So it will not be kind of, I'm not expecting you to give a very elaborate answer. I'm just expecting you to give very to the point, brief answers, and not to tell a lot of things, but to give the kind of exact whatever is asked for. In the clinical case-based scenario, also it will be kind of you'll be having 15 questions, and 15 questions will be over the 15 minutes. So for each questions, you will be having 1 minute. So if after 1 minute you will be passed to the next question, irrespective of whatever you give questions or not, because in EDIC examinations, examiners are bound to complete their questions. So here we'll also follow the same thing. I'll be bound to complete all these 25 questions in clinical case scenario within that stipulated period of time. If you do not give answer within 1 minute of time, I will stop you and then I'll move to the next section. Is that okay?
Yes. Okay.
Thank you. Thank you. So with that thing, so now I'll just on like the timer on. So we are already 10 minutes late. We'll have to finish by 4 at least. So before we go, we'll just go through the first clinical case vignette that I have just presented to you. Can you see the first clinical
Yeah,
case
I
vignette?
see. I see.
Please go through this clinical case vignette, and your subsequent questions will be on the basis of this clinical case vignette. If you have any doubt at any point of time, just ask me the questions. I'll give you just 1 minute of time. Your timer has been just started. I've just started your timer.
Thank you.
Can you move? Can you start the questions?
Yeah, I'm reading the question already.
Yeah, okay. Once you're done, please let me know.
Okay.
Should I read it out for you, or you can read
No,
and...
no, no, I can do it. It's okay. So I'm done. It's okay.
Okay. So just remember the entire case scenario, because your entire case will go on the basis of this case vignette only. Okay. So the first question is, what are the practical challenges in resuscitation of this patient? Because you have been called for the resuscitation of this patient, this gentleman who has been kind of found drowned and all. So
So
what are the
first,
practical challenges in the resuscitation of this patient, and how will you overcome these challenges?
okay. So first of all, this patient, she is hypothermic. That's why she is on acetone. The challenge is the vasopressors medication like adrenaline, it will not work easily in this patient. So that's why we need to rewarm this patient during the CPR. Because without rewarming the patient, we cannot achieve the risk. How we will overcome? So we need to continue CPR for sure. We need to rewarm the patient as soon as we can. So the vasopressors and all medication that we are given, it will work, and maybe we can achieve risk.
How will you overcome the challenges? Do you have any answers to it? Like hypothermia is a problem you have stated. So how will you counteract the? How will you address the problem of hypothermia? How will you?
So the
How are you
question
planning to
is how
warm
we
the
can
patient?
rewarm. I'm sorry. So the question how we can rewarm the patient.
Yeah.
Okay, so we can use the external methods like blankets or this stuff. Maybe this is difficult for this patient as she is in CPR now. We can use the warm IV fluid. In some cases, we can use also even CRRT or even ECMO to rewarm this patient.
Okay. Is there any other problem apart from hypothermia in this patient during the resuscitation?
Um,
Is there any
uh,
other challenges?
can I see the question again, or it's not allowed for me during the exam?
Yes.
Thank you. So the outdoor temperature is still low, so we need to transfer the patient to the hospital. I'm not sure the scenario is giving me. Yeah, she is in the ER. Um, okay.
Okay, we'll move forward.
Yeah.
What are the salient points of resistance protocol in hypothermic patients? You have covered to some extent. Do you want to emphasize certain other facts regarding the hypothermia protocol, resistance protocol, the ACLS protocol, or you?
Yeah, we can use this modified ACLS protocol in the hypothermic patient, as we have to continue stress compression for sure. We have rewarmed the patient. If the temperature is less than 28, so we can delay a little bit the vasopressors, or we can give the adrenaline every 3 minutes, not every minute like the regular protocol. When the patient temperatures increase to the 30, so we can resume the protocol as normal, as regular patients.
Okay. And what are the prognostic factor determining overall outcome in this post-drowning hypothermic out of hospital cardiac arrest? So these are the three challenges that you should have mentioned in the any resuscitation, because they are the challenges. Anybody out of hospital cardiac arrest is a challenge, hypothermic is a challenge, and is a drowning patient is a challenge.
Okay.
So again, what is the prognostic factor?
Prognostic factors that determine the overcome outcome, it will be the duration of the cardiac arrest, the duration during the transfer to the hospital, and the time to the rewarm the patient. And of course, the age of the patient and other comorbidities of the patient.
Okay. So we'll just continue. The RSC has been achieved after 65 minutes of CPR. Patient was intubated, ventilated during resuscitation. After ROSC, patient was shipped to the ICU, comatose, but hemodynamically stable with time. What will be the post-resuscitation care for the initial 72 hours of this patient? What investigations you need to send, and what plan of treatment? So they're the two 5A, 5B canon.
So in the first 72 hours, I would like to keep the patient sedated.
So first thing, what investigations you will send after the patient, after you achieve the ROSC?
Sorry, again, I didn't hear you.
What investigations will you send for this patient for further evaluation after you achieve your ROSC, return of spontaneous circulation?
Okay, so you are asking me about investigation, not the
What
care.
Yes,
Investigation. Okay.
what investigations will send?
Okay. Okay, so I would like to do for this patient a CT scan or MRI to the brain. I would like to do a EEG. I would like to do a specific annulase antibody to predict the diagnosis. With the other lab tests like the regular lab tests like CBC, kidney function test, and other lab tests.
Okay. What time you will prefer to do a CT scan and EEG for this after ROSC?
What
Will
can I
you
see in the CT scan?
Yes. When will you
Yeah,
do CT scan for the patient in
to
ROSC?
detect if there is any signs of anoxic brain damage, like, for example, brain edema or specific infarction in other areas of the brain.
So will you do a CT scan on EEG for all patients after post
Uh,
cardiac arrest?
And we don't know what happened before cardiac arrest. Maybe she had the trauma or something or bleeding. We don't know, as we didn't witness the arrest by ourselves.
Okay. What will be your plan of treatment in the initial 24 to 48 hours?
Oh, I will go for a neuroprotective measurement in the ICU. So I will go for this. Maybe the ICP will be high. So I will go with deeply sedated for this patient. I need to keep the to give good oxygenation for her, like PO2 will be high. I would like to keep the CO2 between 30 to 40, sodium more than 140, glucose control for sure, to avoid fever, avoid seizure, as much as we can, as much as I can.
Okay. So we have said the day one labs. We have been given provided the labs and sent in the day one. Just go through the values
Okay.
and we'll move forward. So patient remained on a ventilator in ICU. After 3 days, patient started developing fever. His oxygenation started to worsen. He started to requiring non-adrenaline support. His GCS remained E1 VT M2. You sent a day 3 labs, which came like this. And you have been provided with an X-ray picture of that patient.
Okay.
Your question 6. So explain the current clinical evaluation, and you need to identify at least 3 medical problem here. So again, in EDIC, they will not very specifically tell you 3, 4, 5, but I have very specifically mentioned 3 because in any scenario, you need to find at least this kind of.
Okay.
Just enumerate what are the problems we are having.
Okay. So the patient, she is febrile. She is now on noradrenaline. So most likely she has septic shock. She has bilateral infiltration on the CT, on the chest X-ray. So maybe the cause is bilateral pneumonia, or even ARDS, post resuscitation. So maybe ARDS, we can say septic shock. We can say that the source of septic shock is pneumonia.
What is the third medical problem? You have told
Sorry.
septic, yeah, you have told septic shock, you have told pneumonia. Although I'll take it in a kind of same spectrum, but again, if I
Okay,
again
cardiac dysfunction, maybe cardiogenic shock, as this patient, she is post resuscitation and she has bilateral infiltration on the chest X-ray. So even cardiogenic shock, it will be the diagnosis.
any other
Can be.
medical problem you can find out. I'll again go back to the first day lab and
Okay, wait a minute, please. Just show me the previous one. Sorry. Thank you so much. Hemoglobin, white blood cells, platelet, creatinine, bilirubin, liver enzymes, alkaline, albumin. Okay. So
okay, move forward.
white blood cells, acute kidney injury also. She developed now acute kidney injury, and even liver enzymes
That is why I wanted to know. So in EDIC 2, you'll be asked very specific questions. You will have to tell acute kidney injury, otherwise your marks will be deducted.
Okay.
So what will be your plan of management?
So for this patient, I
So
will
again, so I have decided again in the EDIC 2, they will not divide your questions like this. So whenever they ask you regarding the management, then you need to tell what investigations you will send, what treatment you will give, what will be the challenges. So all these things you'll have to go. Just see the questions and tell one by one.
Okay. What will be my plan or my plan of management? What further education will you send? And what treatment will you
This
go
patient has
in?
developed
How
septic
will you
shock with acute
sustain?
kidney injury after
Okay.
3 days in the ICU. So what
Okay.
investigations will you send?
Okay. Okay. So for this patient, I will take a management of the plan. I will take full septic workup, blood culture, sputum culture, and culture. I will go to measure also lactic acid. I would like to give her a fluid challenge to make sure that she is responsive to fluid, yes or not. And what the fluid? It will be ringal lactate. We can give 30 cc per kg within 3 hours. I will give a wide spectrum antibiotics. Um, how will you resuscitate? I will, as what the fluid? I said fluid will be ringal lactate 30 ml per kg. Then I will have to assess the fluid again if the patient is fluid responsive or not. How I monitor the progress? I can monitor the progress by the dose of the support of noradrenaline increasing or decreasing, and by also evaluate the fluid status if this patient needs more fluid or not.
Question number 8. Does this patient have AKI and what stage of AKI he is in?
For sure, this patient, she has an AKI. What stage? Sorry, I forget the first number and the second number of creatinine, and still I need to know the urine output of this patient, but I will
What are the
say
stages of AKI?
again.
What are the stages of AKI? It's a general question. What
Yeah,
is the
yeah.
stage?
According to CATICO guidelines, stage 1, stage 2, stage 3. So most likely this patient will be in stage 2.
Okay, what is stage 1 AKI?
What is stage 1? Stage 1 is increase the creatinine 0.3 from the baseline within 1 day, or doubling the creatinine within 1 week, or decrease the urine output less than 0.5 per kg per hour for 6 hours. 6 to 12 hours. This is
What
stage
is
1.
stage 2 AKI?
Stage 2 AKI is doubling the creatinine from 2 to 3 times, decrease urine output less than 0.5 for more than 12 hours.
What is stage 3 AKI?
Stage 3, if the patient underwent hemodialysis or creatinine more than 4, or decrease the urine output less than 0.3 more than 6 hours, or anuric patient.
Question number 9. What are the probable causes of AKI in this patient?
So this patient, she is post CPR, so maybe hypoperfusion to the kidney. So during resuscitation, this is one cause. Sepsis or septic shock may be the other cause. Nephrotoxic medication may be also the cause of this is maybe the causes of the AKI.
Any other cause you can remember?
Any other cause for this patient? I will say we have to rule out, of course, obstructive cause like maybe
The background of hypothermia.
hypothermia. Yes, maybe hypothermia due to diuresis during hypothermia, so maybe it's caused hypovolemia and also AKI.
Okay, we'll progress. Day 5. He remained hemodynamically unstable. He's on dual pressures. He's intermittently febrile, started to become oliguric. His GCS is E1, M1, VT. His FiO2 on the ventilator increased to 70%. His cumulative positive balance of 12 liter in 5 days. He have been provided with the day 5 labs. His create got increased, sodium, potassium, bilirubin, liver enzymes, albumin, and have been provided with an ABG, arterial blood gas balloon. So, sorry. Are you okay? Are you done? Can you go
Yeah,
through?
I'm okay.
Does this patient require RRT?
Okay, so This patient, she had already hyperkalemia and severe metabolic acidosis. If the potassium, if we cannot treat the potassium and the acidosis medically, so this patient will need CRRT or renal replacement therapy anyway. What's the type? What the indication of RRT in the ICU? If we had refractory pulmonary edema, refractory metabolic acidosis, refractory hyperkalemia, or signs of uremic signs like uremic encephalopathy or uremic symptoms. So these are the indications of RRT.
What are the different types of RRT? What form of RRT will you prefer for this patient and why? And what vascular access will you use? What will be preferable site of cannulation?
Okay, so the difference of RRT, we are speaking here on hemodialysis, not on peritoneal dialysis for sure. Hemodialysis, it could be intermittent or it could be CRRT, continuous renal replacement therapy. For this patient, I will prefer to go for CRRT, continuous replacement therapy, although there is no evidence that intermittent CRRT is over the intermittent hemodialysis, but as the patient, she is on dual vasopressors and patient in critical conditions, so I will go for CRRT. Which type of CRRT? This is the question, or that's okay?
What vascular access will you use?
Vascular access, I will go for, of course, is preferable to go for right jugular access. This is the preferable size for cannulation.
What are the different modalities in CRRT?
CVVH, CVVHD, CVVHDF.
Can you please expand the full form?
Sorry, again.
What is CVVH? Can you please expand it?
It's continuous venous hemofiltration, or continuous hemodialysis, or continuous veno hemofiltration.
Hemodiafiltration, right.
Hemodialysis, yes.
How do you adjust the dosing of CRRT? How do you calculate the different dose in CRRT?
Yeah, I will go from the dialysis dose, it will be 25 to 30 per kg.
Okay. And how will you calculate different dose in CRRT? What is the different dose in CRRT?
Yeah, I can divide it as half to half or 1/3 to 2/3, according to the patient's
How will you
situation.
calculate the effluent dose in CRRT? What is the formula of calculating effluent dose in CRRT?
I will calculate the whole. Actually, in my unit, the nephrologist do it, not me. But as I know, we can. It's depending for the depending on the mood of the CRRT. But okay.
What are the different anticoagulation? I'm sorry. What are the different anticoagulation used in CRRT? What anticoagulation will you use for these patients for running CRRT?
So we can use a heparin drip in the CRRT or regional anticoagulation, which is straight. For this,
patient?
yeah. Again?
Yes. What anticoagulation will you use for this patient?
Oh, for this patient, as this patient, he has, I don't know if if there is liver failure or not. If there is liver failure, so the citrated will be contraindicated and we'll go for just heparin. If not, we can this patient we can do heparin. We can do heparin drip. There's no
What
contraindication.
makes you feel that this patient is having hepatic failure?
I saw the liver enzymes are high a little bit, but I don't know the bilirubin, the albumin. They were low. Okay, again, please. Yes. So liver enzymes are high, albumin is almost normal, lactic acid is high. I don't know the the INR is high or not to complete judge, but there is no liver failure, I think, no.
What is filtration fraction?
I don't know.
Okay. How will you determine the dose of citrate anticoagulation and what monitor will you use while using citrate anticoagulation?
Yeah, it's according to ionized calcium.
Ionized calcium of what? Can you please expand?
Pre-filter and post-filter.
What will be a normal value of pre-filter ionized calcium and the post-filter ionized calcium?
The normal, the range you mean? I don't know. We have to call it.
Sure. Okay. This patient required one cycle of CR rotations in the last 24 hours. The patient hemodynamically became better, requiring minimal vasopressor support. Kidney function improved partially over the next 2 days of time, but patient remained unresponsive. This was E1 VTM1. We suspect a possible brain death state. How will you evaluate a potential brain death patient, and how will you diagnose a brain death state?
No. I will evaluate the potential brain death. I will diagnose the brain death. First of all, I have to stop all the sedated medication, all the medication that affect the brain function. I have to make sure that there is no abnormal lab test that interfere with the brain death examination. Then I have to evaluate the brainstem reflexes, apnea test. Then I will proceed to it's not mandatory, but we can proceed to EEG and cranial Doppler ultrasound.
What reflexes will you test for testing a brain dead patient?
Again, please, the question. Sorry.
What reflexes will you test in this
brainstem reflexes? We are speaking about corneal reflex, ocular reflex, gag reflex, papillary reflex pupils, then the apnea test, but it's not part from the cranial reflex for sure.
How will you do apnea test?
So an apnea test,
yes.
Yeah, so an apnea test, we need to make sure that saturation is above 95 during the whole test. We can measure the ABGs and to see the CO2 before the test. Connect the patient to tracheal mask or to two-piece to the oxygen directly. Then to observe the patient if he had any respiratory effort for 10 minutes. Then we can take an ABGs if there is no any respiratory effort and the CO2 increased by 10. So this is diagnostic for apnea test.
You're sure the values, regarding the values, whatever you have told?
I said 10, this is 20, not 10.
Do you do apnea test regularly in your ICU?
Again, sorry?
Do you do apnea test regularly in your ICU?
No.
Okay. What are the common confounders in an apnea test?
During the apnea test, if the saturation decreased or the patient he has a pulmonary problem, so we cannot proceed with that test. If we cannot keep the saturation more than 95 during the test, so we have to abort it. So this is the problem. If that's the question.
Means what are the states where we cannot do apnea test?
When we cannot do the apnea test?
So they are the confounders.
If the patient he has oxygenation problem, so we cannot do that.
Okay.
If the patient, if he not hemodynamically stable, also we cannot do that.
Okay.
Hemodynamical instability, we said oxygen if the patient he have a problem with the oxygenation, so we cannot do that. And that's it. This is what I know.
What is the role of ancillary tests in diagnosis of brain death state? Do you know any ancillary test to diagnose brain death state?
Was that test? Is there any other name for this test?
So they are called as standard ancillary test for it's a so this diagnosis, this brainstem death is a kind of one important thing that each and every intensivist needs to know, and there is a very standard criteria and the diagnosis for diagnosis of brain death patients. This is a very common question even in the EDIC type 2 and European.
Thank you for asking.
Just go through that. Anyway, how do you communicate this current clinical status to the relative?
To the relative. So we can speak to the relative.
How do you communicate
about how I can. Sorry, you are asking me about the step of communications or on the information that I have to provide to the relative.
Yes, what information you will provide the relative and how? Suppose I am the patient's relative and
Okay.
the patient is one of the close relative of mine, and you're the treating physicians. You are managing these patients for the last 5 6 days, and now you feel that he is probably brain dead. How will you communicate that thing to me?
Okay, so first of all, we have to sit in the private room with the private settings. I need to ask the relative what they are knowing and what they are expecting from their patient. Okay, because we need to break this bad news. Then I will start to explain to them that the brain is not functioning. So unfortunately, there is no hope or the possibility of recovery is almost none, then we have to discuss the other plan for organ donation or terminate or even disconnect the ventilator.
Can this patient considered for organ donation? Do you think that suggesting an organ donation will be a good idea if the relatives accept a brain dead state? Should we give them an option of organ donation?
Yes,
Okay,
yes,
sure. Okay, so that ends the clinical case scenario. We'll move to discuss case-based scenarios. Is that okay?
okay.
We'll discuss probably in a separate debriefing section. We'll discuss how we have performed and all, but we'll just continue the case-based scenario. So your first question is 26-year-old male admitted with a RTA, sorry, hemodynamically unstable, ongoing resistance, chest X-ray is done, chest X-ray is like that. Describe the X-ray and what will be your plan of management. Very brief, to the point, just give an answer. What is it? Describe the X-ray, please.
So I can see hemothorax in the left side. Okay. I can see pneumomediastinum. What is my plan? This patient need, I can see also chest tube, if I'm not wrong. I can see left chest tube. This patient needs urgent operation. So what my plan management, it will be start with ABC resuscitation, massive blood prepare for blood transfusion, and this patient will need immediate surgery.
Any other silent feature? If I
Any other one?
Any other thing you want to mention about the chest X-ray? You mentioned hemothorax. You
Okay.
mentioned a chest tube. You mentioned some pneumomediastinum.
Hemoperineum.
Other things very
Right.
important. I'll give you
Lips,
one thirty
lips.
seconds more time.
Again, sorry.
I'll give you some more time. 10 seconds more.
Okay. Ribs fracture
Which side?
and ribs on the ribs fracture on the left side, and I can see oscoscapular fracture if I'm not wrong.
Good. Rib fracture. Please mention. So another 45-year-old gentleman, road traffic accident, low G stance, breathless, hypoxic, vulnerable to ER, emergency intubation done, CT brain done after intubation. So describe the CT scan and how will you grade the severity? Describe the
So
CT scan, please.
yeah, this patient he has subarachnoid hemorrhage, post trauma. The grade severity, I don't know.
Any other thing you want to mention apart from
Brain
Savar?
edema, brain edema, compressed ventricles.
Please complete your, otherwise you will be deducted the marks. And in the EDIC 2, trust
Oh,
me, they will not give you clues, hints, and anything.
okay.
Subarachnoid hemorrhage with brain edema, compressed
Ventricles, yeah.
ventricles, norsing, sulci gyri, everything you have to mention. When I'm telling you to describe the CT scan, blood in the sylvian fissure, everything you have to see. Anyway, sorry,
Okay.
everything come with the debriefing. How will you grade the severity in a patient with the
Mm,
ACH?
I pass. There is no-
Okay. So chest X-ray of the same patient after intubation. Describe the X-ray. What will be your plan?
So we can see infiltration on the upper lobe, right upper lobe. Okay. This patient is intubated. I can see the ET tube.
What will be your plan?
Plan. I will go for lung ultrasound, okay, to see what is this infiltration, and maybe chest tube also.
You want to put in chest tube for this gentleman?
After I would like to do first sorry, what is lung ultrasound, and the tube is locked deep and it's like selective lung intubation. I will go pull out the tube a little bit.
Okay. 24-year-old female, PCOD on an OCP, admitted with chest pain, mild hemoptysis, breathlessness since his study, ECG, having sinus tachycardia, CT scan has been provided. What is your diagnosis?
So there is bilateral pulmonary embolism on the CT scan,
Okay, very good.
right and left. What I decide plan is according to the patient status. If the patient hemodynamically stable, I will go for the anticoagulation. If not, I will go for thrombolysis.
Which patients you will thrombolize and which patients you will anticoagulate?
Sorry, again.
Which patients will you thrombolize and which patient will you anticoagulate?
If the patient hemodynamically stable, blood
Okay.
pressure is okay, I will go for anticoagulation. If the patient hemodynamically unstable, I will go for thrombolysis. Unstable, thrombolysis. Stable, anticoagulation.
Is there any way to grade the severity of pulmonary embolism clinically? Is there any clinical grade?
Yeah, we can do echo to check the RV strain, but still the definition of massive pulmonary embolism is hemodynamically instability. So if you are asking a plan of management, so yes, we can go for the echo to check the RV strain, to check the severity of the patient. I need to take history to know what if this PE is provoked or not. Then for the treatment, anticoagulation and hemodynamically versus thrombolysis in unstable patient.
What is high risk pulmonary embolism?
High risk high risk if the patient have RV strain on the echo, okay, and
How will you understand RV strain in echo?
define
How will you understand RV strain in echo?
if the RV is big, like the size of RV will be equal, almost equal to the left ventricle.
Very good. Any other thing? Sure, we'll proceed.
That's it. Okay.
A young lady admitted with a fever for 2 days with an episode of seizure and the right upper limb weakness. MRI brain has been done, and what is the diagnosis? And how will you manage? So this is the sagittal section of the MRI brain of this lady.
MRI and okay, that's not fever, episode of seizure. Pass. I will go back for that.
Sure. Describe this graph and what actions will you take? What is this graph?
It's the flow volume loop. Okay. We can say that the expiration is not returned to the zero. So maybe this is a leak.
Okay, very good. What actions will you take?
Just to check the cuff of the ET tube, check the circuit if there is any leak.
How will you confirm that whether it is a leak or not?
Sorry?
How will you confirm your diagnosis that whether it is leak or from where it is leaking?
First of all, I will check the ET tube cuff. if there is leak from there or not, I will inflate it. If everything is okay, so I will go back to the circuit. So I will exclude it place by place, if that's your question.
Okay, sure. Thank you. See the ventilator graph, and you will have to tell me what mode of ventilation it is. You will tell me what kind of respiratory problem we are dealing with over here, and what will be your plan of intervention.
Sure. First of all, this is an volume control. Okay. This tidal volume. This is volume control. Okay. This is the type of ventilation. Describe the respiratory problem. The peak pressure is high. Peak pressure is 37 and the plateau pressure is high, also 32. Here we can see the respiratory rate is high. There is the peak pressure is high for because the inspiratory and expiratory time, both of them are so low. I will go to decrease the respiratory rate. I think it will fix the problem.
So, what respiratory problem this patient is having? Who is on this mode of ventilator? Who is on this ventilator setting?
ARDS or some restrictive lung disease.
Why do you say it is ARDS or restrictive lung disease? What makes you think so?
Because the tidal volume is low, respiratory rate is high. Sorry. No, I cannot say that because the PEEP is low. So this is against that. And the IE ratio is 1 to 2. Also, this is make the things not good.
Tell me, what is the static compliance of this patient?
Static compliance here. Do you want me to calculate it? Yeah, this.
Yes, I want you to calculate that.
Okay, so the static compliance, it will be the tidal volume is 270 over the change of the pressure. We are talking about static plateau pressure minus PEEP. 32 minus 5. We are speaking about 27. So the static compliance will be 20 change of the pressure. So it will be 170 or divided by 72 is 10. Slow.
So, static compliance is low. Is that right?
Yep.
So, what will be your intervention in this patient?
Again?
What will be your intervention for this patient?
What? Again, I'm sorry.
What will be your intervention, or do you want to change the ventilator setting?
Intervention. Okay.
What will be the
So,
intervention?
if this patient he has restrictive lung disease, I will go with and maybe ARDS. I will go with decrease the respiratory rate for sure, and maybe even increase the PEEP.
And suppose this patient is on ARDS, what will you do?
Increase the PEEP, decrease the respiratory rate. IE ratio, it will be 1 to 1 if there's a problem in the oxygenation. And finally, pump position if we cannot achieve the oxygenation for the patient.
Good. We'll proceed. What mode of ventilation is this? What is the problem over here, and how will you counteract?
Okay. So I can see ineffective trigger.
What mode of ventilation?
Mode of ventilation. Pressure, volume. Is a pressure control. I'm not sure if it's control or not, but it's a pressure mode. Okay. And the problem here is ineffective trigger. So
pressure control, or what did you say regarding the mode of ventilator? Sorry, I just missed that. Pressure control ventilation, you show it?
I can say control. No, it's not control. The patient can trigger the ventilation still as the tidal volume is not equal, as I can say.
What mode of ventilation it is?
It is equal?
Which mode of ventilation is this? So what mode of ventilation is it?
Okay, pressure. It's the pressure
Pressure?
mode. Yeah.
Is it pressure control or pressure support?
Yeah, it's the pressure support as the patient is triggering the ventilator. And the problem here is ineffective pressure. Okay,
How will you
ineffective
how
trigger,
will you
sorry.
how will you counteract?
Again,
How will you counteract this ineffective trigger?
yeah, decrease the PEEP. Um, decrease the PEEP. It will and decrease the sensitivity of the trigger.
Okay, we'll proceed. Question number 9. 65-year male came to ER, severe crossing chest pain. While being evaluated, collapsed suddenly. CPR started as per ACLS protocol. Intubated while on the ETCO2 monitor. So this is the ETCO2 monitoring while ongoing CPR. How will you interpret this stressing? What is the role of continuous waveform capnography in CPR?
So we can see the end-tidal CO2 monitor showed low tidal CO2. This means the compression was not effective or just initiated. After that, we can see that end-tidal CO2 is above 45. The chest compression will be effective if the end-tidal CO2 more than 35. So this is the rule to maintain good compression or effective compression. It has the capnograph will be more than 35. Maybe the patient here achieved the ROSC. We don't know.
And how will you interpret this sudden rise in ETCO2?
ROSC,
Yes, sorry.
ROSC, return of
Yeah.
spontaneous circulation.
Okay, thank you. Question 10. There's a patient, acute kidney injury, post cardiac surgery, persistent metabolic acidosis, oligory for last 6 hours, done vasopressors. Pressures. ECG is showing like this. What is your diagnosis? And how to manage?
Okay, this is white complex AST.
Tell me the ECG. What is the ECG?
Yeah, I can see the ECG, but just I'm thinking there is, sorry, pacing. No, not pacing. Okay.
Anything? Just describe. Try and describe.
I'm trying to. So the QRS here is white.
Can you
Okay.
see? Okay, I'll help you out again. Sorry, I'm not allowed to help, but again, in an exam, nobody will help you.
Yeah.
Can you see P wave? So whenever you're trying to see ECG, you will see P followed by Q, then
P is
R.
not followed by P. There's no association between the peak P wave and the QRS. So maybe I will say complete heart block.
Okay. So what's your diagnosis?
Sorry,
What's your diagnosis?
complete heart block. Grade 3 heart block.
You've been given a background of.
Again,
You've been given a background of the problem over here. How will you manage? I
if
think
I say if I say this is a complete heart block, so we will say sorry, atropine, adrenaline, and pacing, but it seems my answer is not correct. So
can you proceed?
yep, sure.
One more ECG, 56-year male admitted with sudden onset crossing chest pain. On examination, perspiration, full extremities, breathless, hypotensive. ECG has been taken. What is the diagnosis?
So there is ST elevation in lead 2, lead 3 AVF.
Yes.
Still, we have also an elevation in V1, V2, a little bit in V3 with reciprocal changes. So we will see infro anterior ST elevation MI. The immediate management here, this patient should receive immediately aspirin, Plavix, statin, oxygen, and refer her for urgent cardiac cath.
Okay. Question number 12. A female diagnosed with B cell NHL. She had non-oliguric renal dysfunction with anemia and transaminitis on admission. Received first cycle of R-CHOP. Post chemotherapy, her renal function worsened and she developed pancytopenia. So we have been given a set of values: hemoglobin,
Okay.
WBC,
Yeah,
platelet.
pre and post. So we can see that she had now hyperkalemia is increased, hyperphosphatemia and low calcium. So I will and and increased kidney function test. So I will say tumor lysis syndrome. How we prevent is by giving IV fluid and good hydration and respirase. And for treatment, if we failed, we can go for hemodialysis.
Thank you. Question number 13. A 35-year-old female known case of Sjogren's on intermittent steroid. Admitted 2 weeks of fatigue, poor appetite, nausea, vomiting, confusion, bilateral pain, abdomen. Vitals have been provided to you. ABG has been provided to you. Just go through the ABG, and there are a set of lab values which has also been provided to you.
Okay, so Sjogren's syndrome and intermittent steroid, confusion, poor appetite, nausea, vomiting, confusion, bilateral pain. The ABGs, we have metabolic acidosis. Anion gap is roughly sodium 144.
There over there, describe the acid-base balance and what will be your next best test for the diagnosis. Describe the acid-base balance first, please.
Yeah. I'm checking the anion gap now. We have now here metabolic acidosis. The anion gap is 21 So the anion gap is normal, and by giving the anion gap here is normal, sodium is high, potassium is low.
How much is the analysis, by the way?
Anion gap now here is 10.
Okay.
Is 10, I'm right? 127, 100, sorry, 127 plus 7, 100.
Okay.
So again,
So
sorry?
describe that acid-base balance.
Yeah, discovered acid we have normal anion gap, metabolic acidosis. Okay. We can measure the compensation 105 by 1.7
So what tests will you order on the basis of this clinical picture and this normal and gap metabolic acidosis?
so maybe this patient, she has Addison disease, as she has hypertension with normal anion gap metabolic acidosis, so I will have to order cortisol level.
Okay. What test do you order next when you see somebody with a normal and gap metabolic acidosis? Okay.
Sorry, I can, okay, okay.
So we have done a urinary electrolytes for this patient to understand urinary anion gap. So now tell me your diagnosis. And we have done a CT scan for this lady. What will be your diagnosis? And how will you manage? First diagnosis.
So, okay, so it's RTA type 1. As this patient, she has a stone in the kidneys.
Oh, I've marked it also.
Yeah. Yeah. Okay, she has kidney stone and she has also normal and metabolic acidosis. So, and a pH in the urine is 6.5. So maybe this patient, she has RTA type 1, renal tuberous acidosis type 1. Manage that it will be with bicarb and good hydration for sure.
Okay, sure. We'll continue. So one patient with ALF means acute liver failure. He's on CRRT, he's on a ventilator, he's on effluent dose of 3 liter per hour, he's on citrate anticoagulants with a citrate dose of 3 millimole per liter, and with calcium chloride infusions. The patient has suddenly become hemodynamically unstable with bradycardia, ECG's QTC prolonged, and the ABG has been provided to you. pH, PO2, PCO2, bicarb, and then GAC, lactate, sodium, potassium, ionized calcium, everything has been provided. Okay?
Okay.
What's the diagnosis and how to manage?
Maybe this patient, he has citrate. Citrate is high, and this is caused lactic acidosis. So I will give regional citrate or regional anticoagulation in this um, dialysis, and I will give calcium IV.
You will give calcium and okay, you will give calcium and what else do you want to do?
I will stop the citrate infusion.
Okay, very good.
Okay. Give calcium.
Yes, and
And try
the
to
last
correct acidosis with bicarb.
okay, last question. A 16-year-old boy came with a history of chronic cough and fever for the last 2 days. Chronic cough and fever for the last 2 days. Sister did an ECG and so on to the nursing staff did an ECG and so you the ECG. Describe the ECG and what might be the most likely diagnosis for this boy. What do you think the ECG?
Okay, so the ECG, I have irregular rhythm. Okay. And I can see the P wave, but still this is irregular rhythm. And I can see in some heart block, it's complete heart block.
Complete.
Like,
So I think that ends our. I think that ends our. Uh, that ends our question and answer CBS session as well. So thank you, Dr. Haitham.
okay, thank
Thank
you so
you
much.
for all your attempts, and then I'll come to you for a debriefing section in a due time. I've just been in touch with the the course coordinators, so I'll be in touch with you. Okay.
Thank
Is it?
you so much. Thank you.
Thank you very much. Thank you for joining.
Thank you, sir. And
Uh,
thank you, Dr. Haitham.
yes.
Thank you.
Thank you. Yeah.
There's evaluation for that, or just with debriefing session?
Yes, in the debriefing section, I'll come back to you, Dr. Haitham, and I will give an idea that what are the things probably you might have missed, what are the questions where you have some scopes of improvement, and what are the questions where examiner wants something different, and what are the questions you have done very excellent. So there are certain segment where you have done good. There are certain segment you need certain amount of improvement. So we'll discuss all these things in the debriefing section, and maybe you can go through your the entire examination section. Probably you can get a video, probably recorded video of the entire session from the exam coordinators, and you can go through and then you can see the entire sessions, and you can decide what probably you might have missed or you might have improved. But there's a certain point of time I tried to give you some amount of hint, but in EDIC 2 exams, the examiners usually sit with a very masked faces. They don't give any expressions. You will not be able to understand whether you're telling right or you're telling wrong. The examiners will be absolutely emotionless. They will have one of the iPad or something like that in their hand. They have, along with the questions, they have the answers also along with them. They will just tick 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 whether you have answered certain things or not, or you have missed certain things or not. Based on your answers, you will get marks. So it's very objective kind of test. So I try to keep the exam format as closely as possible to the EDIC 2 exam. But again, we'll discuss a lot regarding this probably.
Thank you, sir. Thank you so much.
Thank you so much. Thanks a lot. We'll see you again.